Good afternoon, everyone. So today Robert is in the another meeting, as you know.
Yes.
So I take care of today's hosting. So today I'm very honored to introduce our speaker, the Professor Quentin Böhler. He's an assistant professor of the robotics at IMAFT, where he leads the medical robotics lab. Right? So Professor Böhler received his engineering degree in the mechatronics from the INSA Strasbourg, and his master's and PhD in robotics from the University of the Strasbourg. He then worked here as a postdoctoral researcher and senior scientist in the Professor Bradley Nelson's multi-scale robotics lab. His research focuses on the robotics system for the medical application, particularly for the minimally invasive procedures. His work includes the continuum robots, the magnetic navigation, and autonomous systems to improve the surgical precision and safety. And he also has published over 50 more papers in the leading journals and serves as an associate editor for IEEE Robotics and Autonomous Letters. So in today's talk, he will discuss recent advances in the medical robotics and how these technologies can be translated into the real clinical applications. So please welcome Professor Böhler.
Yeah, thank you very much. It's a pleasure to be here. So as you mentioned in your introduction, I'm a new faculty here, but I'm not new to ETH. So for the talk of today, we're actually very fortunate to have many of the first author of the works I'm going to show you today, who has been doctoral students with me and who I worked with over the last few years. And so, as been mentioned in the introduction, I'm doing medical robotics, and as many of you may know, this is a very exciting time to be in medical robotics nowadays. These systems have demonstrated potential across many surgical specialties. So you can see a few of them here. And there are great opportunities in robotics research for these systems because there's a growing body of literature on emerging promising technologies that can be used in this kind of systems, and some of which I'm going to talk about today, including continuum robots, magnetic actuation that's been mentioned. The first thing I wanted to mention today is that, and that's my experience as an engineer and a researcher in this area, is that to provide relevant solutions in this area, in this context, it really requires to bridge a gap between the roboticists and the surgeons. And that's something I experienced many times when we worked with clinical advisors toward proposing solution, is that we have a lot of misconceptions and very different respective expectations when it comes to come up with what is meaningful in this area. And really what I noticed over and over again is that the key to go forward is collaborating, and that's the very process of generating ideas should be done together with the surgeons, so who are the one who essentially wants to benefit from this technology at the end of the day. And so I mentioned that in the title. I want to explain a little bit what I mean by a two-way journey, because that's what I meant in the sense of the fact of collaborating to translating robotics to the clinic is about approaching, linking these two things together in two different ways. So the first one is maybe what is obvious for engineers is that you want to start from a need and develop a system that answers to this need, right? I mean, you don't need to necessarily to innovate. You can come up with very pragmatic solutions for that. But at the end of the day, you would start from the clinical need. But on the other side, and something I experienced also many times, is that there is a lot of sense to approach things in a more fundamental way and actually advancing robotic research without necessarily a very clear clinical needs in mind. And in the next couple of slides, I want to illustrate a couple of examples on these two different strategies. And the last I mentioned, I mean, the idea of advancing robotic research is what I would call the top-down approach, meaning that actually I meant the first one. So the one on addressing the clinical needs first. That's what we call the top-down approach, where, as I mentioned, you want to derive the systems from the needs. And an example to illustrate that I wanted to use is a project we had a few years ago, where an anesthesiologist actually approached us out of the blue from the Unispital, and asked us to essentially develop a system to help intubate patients. And so intubation is a very common procedure. It's a gold standard to secure the airway of a patient during anesthesia. And according to this anesthesiologist, it actually can be very challenging for his inexperienced colleagues. So what we decided to do is, as I mentioned, to approach it very pragmatically. I mean, this is a proof of concept that actually I've been drawn later on by some of the students who worked on that. But the basic idea is to have a robotic endoscope that help guide a tube that goes down the trachea of the patient, which is the difficult act to perform when it's done manually. And what we proposed was to have this endoscope that is controlled based on the anatomical features that are detected in this image. So typically identify the trachea where we want to place the tube eventually, and steer the endoscope accordingly to center the trachea in the center of the image, and therefore being able to guide the tube over the endoscope. So as a matter of fact, I mean, the work was very well done. We published, we were happy. That wasn't like a technical revolution. We just really approached the problem very pragmatically. Now, a lot of the work I've been doing for the past few years at the Multiscale Robotics Lab, and I very much want to continue now as an assistant professor, actually was very much on the different way, where it was much more of a bottom-up approach, where for many, many years, we've been working on magnetic actuation. And only very recently, we figured that we could actually use it in a very meaningful application on the clinical side. And the clinical problem we've been trying to tackle now for some time, and also as part of Nanoflex Robotics, which is a spin-off company that is based now on this technology, was for neurovascular interventions, and more specifically to treat ischemic strokes. So ischemic strokes, it's a very serious condition that is caused by blood clot that forms in your brain, and it has to be treated very rapidly. Otherwise, it would very much damage your brain. So time is brain. It has to be treated very quickly. What we proposed, I mean, in that case, it made a lot of sense to use our development on magnetically actuated devices. And so this is an example of such a device where you have a magnet at the tip of this guide wire, of this fiber that is deformable. And we use magnetic fields to control the tip orientation of this device and therefore help navigate distally in the brain to help reach the clot and eventually remove it to help the patient. And so, as I mentioned, this technology is actually the product of years of research on robotic magnetic actuation, navigation. And the idea of applying this technology for stroke specifically came relatively recently compared to the moment where it is being explored at the Multiscale Robotics Lab. And a few words on robotic magnetic navigation, because we're going to talk a little bit about that technology over this presentation today. So the idea is to use electromagnets, which are controlled in currents and that are used to generate external magnetic field in space. And by controlling the currents in this electromagnet, you change the magnetic field in space. And if you embed magnetic material at the tip of your continuum robot, so it can be an endoscope, can be a guide wire, can be a catheter, you can basically control the distal orientation of this device. And this is actually what it looks like when we actually applied this technology for endovascular navigation specifically. So this is an experiment we did back in 2021, where we actually tested this technology in vivo in a living pig, and we navigated under X-ray guidance in the neck region of a porcine model. And so that was really like I was about to say conclusion, but we did a lot of work after that. But that was really like the results of years of preparation and research on this technology to bring that into a very realistic condition. And the reason why we have robotic research in this context in the first place is because it's a long journey from bringing this idea to bringing it to something that is actually realistic and can perform a clinically relevant task. And a lot of what we did before getting there actually requires quite a lot of work that is very much related to fundamental contributions and technological development from that point of view. So we worked a lot with simulation. I'm going to get back on that in a second to actually be able to evaluate how these devices are being navigated and how we can design them nicely and control them nicely. There's a lot that has to happen in vitro. So typically in silicon models, so in phantoms, before we actually go on more realistic conditions. So this is actually the neurovascular surgeon that you've seen in the previous video, who's been trained on silicon models for a while before we went in more realistic conditions. And so we actually developed also this. Some of our colleagues developed these realistic silicon models for this kind of training and evaluation. And we also had to evaluate eventually to evaluate typically the mechanical impact of this device for this neurovascular navigation. We actually use ex vivo models. And so that gives you a bit of an overview of everything that has to be done before we can actually really make meaningful steps toward translating this technology to the clinic. So over the years, I've been, as has been mentioned, very much active in the area of robotics for minimally invasive intervention specifically. So a few of the examples you've seen before are on catheters and guide wires. So the one I've shown you before is on neurovascular. So we're navigating into vessels. We can also use this kind of device for more open spaces. So this is an example where we've been working on navigating into the eye to perform retinal surgery. So in this case, again, same principle. We have a fiber with a magnet at the tip. And in that case, the difference is we're navigating in the eyeball and we're trying to inject some drugs behind the retina. So the image you see here actually is called OCT imaging. You can think about it as some kind of an optical ultrasound. So what you see here on the right is the slice of the eye. This is the retina. And this is our fiber here penetrating the retina and injecting eventually this drug behind the retina. And again, a very meaningful use of robotic actuation here because it's a very sensitive layer here and you're trying to gently bring our cannula down to a very specific location and deliver our drug there. And on the other side, and I'm going to mention a few of these examples later on, we worked on endoscopic procedures where the difference between these two is that this time we have a camera at the tip of our device. And again, to perform different kind of procedures. So we worked on gastroenterology, where we navigate in the GI tract of a patient, and we worked on fetal surgery, where we navigate in the uterus of a pregnant mother. Now, really, and that's what we're going to see in the rest of the presentation. My research is very much structured, and I believe actually most of the research in maths, I would say, is structured around three pillars. Where at the very least, probably in my case, this one is a bit unique. But at the very least, we're basically trying to use technologies for clinical needs. And of course, these technologies are very much enabled by working on the fundamentals in our area. And the first aspect I wanted to cover now was illustrate on how what I'm doing oftentimes in this research is to try to make some kind of a matchmaking exercise between a clinical need and a technology. I wanted to use a couple of examples to illustrate that. So this first example, I want to illustrate how one of the aspects we leverage in medical robotics is actuation. And so I already mentioned the magnetic actuation. Now, something we explored a few years ago was trying to combine this magnetic actuation with another approach, which is called concentric tube actuation. Maybe some of you have heard about that. The principle is actually fairly simple. You insert different pre-curved tubes within each other's, and you control independently the translation and rotation of all of the tubes altogether. And so it's actually from a kinematic perspective, let's say, it's a very powerful approach because it enables you, it enables many interesting behaviors so that you can, for example, deploy this device along predefined path. You can control the shape of this device very nicely. And the idea to combine that with magnetics was actually to combine the benefits of concentric and magnetic actuation at the same time. So here you see the concentric actuation where we deploy 3 tubes. Again, as I mentioned, like inserted within each other's, and the magnet is at the tip. Now on this sequence, I'm not using the concentric actuation. I'm just actuating the field, and you see that I have a nice distal dexterity of the device here because I'm only using the magnetic field. And if you combine both, as I mentioned, you have the benefit of both approaches. So you can control both the shape of the device, so you can produce large motion and control the shape, and at the same time control the distal orientation of the device. So again, I mean, this is actually pretty preliminary, but the idea of exploring that in the first place was really to combine the benefits of two actuation approaches to enhance the dexterity of our device. Now, the second example I wanted to cover in this matchmaking exercise I mentioned is a work that we've been doing for quite a few years. Well, Michelle, who's been working on that for her PhD, just graduated very recently. And the project is about what we call laser coagulation, specifically to treat a disease that they call twin-to-twin transfusion syndrome. So in this disease, this is something that affects twins that are developing in the womb of a pregnant mother. And this problem occurs where you have an imbalanced blood flow between these two twins. And if this isn't treated, that eventually leads to the death of the two twins. So very, very critical to treat. And to treat that, conventionally or not, actually, I mean, the way it should be treated is to ablate some of the vessels that are connecting these two twins. And so to do that, we use an endoscope that is inserted within the uterus. So on the right-hand side, you see the endoscopic view of this fetoscope. Inside of this fetoscope is a laser, and we basically are going to try to ablate, so do photocoagulation, right? I mean, we're going to shine the laser on the vessel to close this vessel and eventually save the twins. Now, as you can see on this video, it's actually very difficult to do that conventionally. So conventionally, the surgeon would just see this very tiny endoscopic view. The endoscope would be straight, and they have to navigate over the placenta, which is a very large surface, explore this surface, identify the vessels to be ablated, get back to the vessels and close them. So very, very challenging to do, huge mental load on the surgeons. And so the idea of using robotics here made a lot of sense. I mean, first, because it enables us to expand the field of view of the surgeon and explore the placenta more systematically than we would do in practice. And so in this case, we use the magnetic endoscope, and when we performed an autonomous scanning motion over the surface of the placenta and then stitched all of these successive endoscopic images together to provide an overall field of view of the placenta. And when this mosaic is built, we can use it as a user interface and click on any point of the surface and navigate back to any of these points using visual servoing. And then once you are at the vessel, you use your laser and you can nicely ablate the vessel. So I hope a very good illustration of how, in that case, using robotics made a lot of sense, and where, I mean, we solved a pretty fundamental issue that they had in the clinic. And now that to me that's going to help me transition to the next part of the presentation, where to achieve that in the first place, we had to solve quite a few fundamental challenges that would enable this technology in the first place. And the main fundamental challenge we had to overcome here was to navigate in an open cavity, because the uterus is an open cavity that offer very low texture in the endoscopic imaging. And so to achieve that, we did have to unlock these technological capabilities by solving fundamental problems related to that. And namely, as I mentioned, navigating with visual servoing in low texture image is very challenging. We actually had to rely on the latest contributions from the state of the art on how to achieve that. And that's only very recently that could be done. And maybe something that was not necessarily clear from the previous video is that we are here navigating without any sort of external localization. We only rely on the endoscopic images. And so don't want to get into the details there, but we had to develop a lot of, essentially new approaches and new methodology here to enable that. And here on top, you can see some examples of visual servoing here, where we're navigating one point to the desired target in the endoscopic image. And the reason why it's so powerful because we tackled that at a fundamental level, what is extremely interesting is that we could translate that to other field of application beyond fetal surgery. And so these are a couple of examples where we use essentially exactly the same methods, but in completely different applications. So the first one is in gastroscopy, where we navigated a completely different tool. So actually much bigger and with different tools inside, in that case, a biopsy gripper, and to perform a task in the stomach. So in that case, gripping. I mean, this is in vitro, but this is that illustrate the fact of trying to take biopsy samples on the stomach wall. And the second example here, we're using again this visual surveying approach, but to navigate in the bladder. And as you can see here, the low feature environment I was mentioning, I hope is pretty obvious here. I put you to the challenge to actually detect yourself the features in this image here. But as a matter of fact, our algorithm still works pretty nicely. Now, another fundamental challenge we worked on, and that we realized was pretty important early on, was the ability to simulate soft magnetic devices. And the reason for that is because, well, first we want to understand how they behave, and they have a behavior that is not necessarily straightforward, right? Because we leverage magnetics, and these systems deforms, and they have all sorts of mechanical instabilities. And so it was very important for us to be able to simulate them, and actually even more important to simulate them in real time, in the sense of that we can use this simulation in a proper, like, closed loop control manner. And so we actually did that pretty nicely. I mean, these are very nice results we obtained by using a simulation framework called SOFA, which we adapted to actually incorporate this magnetic actuation in this context specifically. And so we were really happy to see these results. Actually, the people from SOFA were also really happy to see that both the experiment and the simulation match pretty nicely. And to illustrate how that can be leveraged for other other applications, here is a comparison where we actually use exactly the same kind of input, both in terms of insertion and retraction of our device and on magnetic field steering, but with different designs with our tool. And you see here that when we insert the tool into this tortuous vessel, it's going to behave very differently. And so what that means is that we could also leverage that to actually help better design our tool without having to implement them in practice, which can be quite challenging. And as you can suspect, with the emergence of a lot of machine learning tools and reinforcement learning framework, simulators are actually a very powerful and actually necessary tools to use reinforcement learning to train new control policies in simulation before deploying them in reality. What was very interesting for us actually is that we could use this tool, what I want to say, like almost retroactively. So this is actually a result we obtained in vivo, and we could reproduce this behavior in simulation and in vitro. So we essentially segmented the anatomy here of this vessel and reproduced it both in vitro and in simulation. And so that supports a little bit the fact that using these simulators actually, I think, very promising, especially in view of the recent progresses and focus of the community on promoting autonomous behavior in this context. Now, the next fundamental work I've been working on, and I wanted to mention, is about characterizing and evaluating these systems. Because what happens oftentimes when we have this nice platform is that we look at the problem we're trying to solve and we're asking ourselves, can my system actually be used for this application? And so a few years ago, the problem we had is that we didn't really have metrics or methods to actually answer these questions. And I'm a, let's say, classically trained roboticist, and to me, it was very much a question that we would ask from any kind of robotic systems in general, right? I mean, if you work with the robot arm, you're going to look at the data sheet, and the data is going to tell you, okay, this is the amplitude that you can achieve with the joints. This is the maximum payload you can work with. This is the workspace of your system. So actually, the notion of workspace for a robotic manipulator is very well defined. Back in the 70s, we could answer that question. Now, if we look at our system, I mean, again, it's not straightforward at all, right? Because you don't have an end effector. We're using this magnetic field. This control is made at a distance. So wasn't straightforward at all to answer. And so what I proposed, and I'm not going to spend too much time on that, but I essentially developed a methodology and a framework to answer this question in the case of magnetic actuation specifically. And so the question we're asking here, I mean, if I take it from a more mathematical perspective, is this position P in my workspace? And a very classical way to rephrase this question when you work with robotic systems is about taking it from the task side and ask, well, can I actually achieve what I want to achieve at that position? And when it comes to magnetics, a very natural way to define this task is in terms of magnetic field. So you're going to say, for example, well, I want to generate a magnetic field of component Bx, By, Bz in space. And I want to achieve a given magnetic field that is anywhere in this ball, in this magnetic field space. So I define my task. And now the question is, well, what can I achieve with my system? What is the set of available tasks that I can do? And the idea of computing that set of available tasks is eventually to compare that to the set of tasks you want to achieve and do what we call a feasibility test, essentially checking that all of the tasks that in this orange ball are within the set of tasks that are in green here. And so to do that, you have to determine what is the limitation of your system. In our case, there are different ways to define it, but the most obvious one is that there is a maximum currents that you can push in your coils, and so that's what you're going to use in that case. And then we can use what we call a forward model. So we're going to transform that space that is defined in terms of electrical currents and transform it into the set of available tasks at position P. And then we have our set. We can perform a feasibility test. And now you have this nice set of equivalent proposition, which is, well, saying that this orange set is in the green set is equivalent to say that my desired tasks are feasible at P, and this is equivalent to say that P is in the workspace. So again, that was a brief overview of the spirit of the methodology here. And eventually, and you can read the paper if you're interested, but we defined a whole set of methods, of approaches, of metrics that can be used for any system. That's a very flexible framework. And what I was very happy about is that over the few months after the paper got out, I mean, I've started seeing papers working on magnetic actuation systems who actually use that framework to evaluate their own system and communicate the performances, which was exactly the point of doing this contribution in the first place. And internally in our own lab, we actually use this tool to communicate the performance of our system and evaluate the performance of our system in different cases. So some of the two cases I mentioned before, including neurovascular interventions and gastroscopy, we've been using some of the method of the toolbox to provide some answers to that. And maybe the last fundamental aspect I wanted to mention today is localization. So in many of these procedures I mentioned, including endovascular interventions, being able to localize your device in 3D is actually a pretty important aspect, especially when we're talking about achieving highest level of autonomy. And in our case, one of the fundamental questions we ask ourselves is, because we were using magnetics to actuate our device, it feels pretty natural to us to try to also use that for localization and without any additional hardware. And so to do that, well, you want to incorporate a magnetic sensor into your device. And the approach we proposed to achieve that was, well, as I mentioned, we use magnetic field to actuate. So the way you would do it, well, you would change your currents, and this current would change your magnetic field, and that's how you steer your device. And on top of this so-called actuation current, we would add small oscillations, small ripples on this current with frequencies that are different for each of the coils that would these currents would produce ripple in the magnetic field, which would be measured by this magnetic sensor. And then you apply a very standard discrete Fourier transform. So you're trying to isolate the different frequency components for your magnetic sensors. And based on these measurements, which are, it's basically a complex matrix, right? Which each column comes from a different frequency component. And then you solve an optimization problem where you compare these measurements to a prediction that is obtained via calibration, so that you can obtain an estimate of the position and of the orientation of your sensor within this workspace. So that was the math behind. And then actually more recently, what we did is to use the same approach with a slightly different sensor, but at that point, it doesn't matter. The bottom line is we were able to very accurately and precisely localize our device. So here you see the reprojection of the estimated pose on this external camera. And we are now achieving, performances that are actually very well aligned with the clinical requirements for this kind of a localization system. And so we are really happy with this result. And I wanted to finish this part with, all of this fundamental contribution we made to magnetic actuation at the time. That really planted the seeds to some of the most recent works on how to drastically advance this technology, and not necessarily for clinical applications. So one of my colleagues from the multiscale robotics lab, Yasan, who is actually in the room, has now been pushing pretty far the possibilities and the capabilities of the systems. So what you see here is a magnetic inverted pendulum. So an inverted pendulum, just to give you a brief idea of what that is, imagine having a pole that you're trying to balance at the tip of your finger. Well, here the equivalent of the tip of your finger is this bottom pole that is magnetic, and so it is controlled by the magnetic field of the system. And maybe it doesn't look difficult. Try to balance a pole on the top of your finger. You realize that this is an extremely challenging task to perform. It requires localization. It requires very fast reacting time from the system. It's a very hard control problem. And so this task overall is very challenging. And what again was very interesting for me to realize is that the solution that Yasen's proposed to control this system was a pretty big improvement over what was done conventionally. And again, using this workspace characterization framework, we were able to show quantitatively that his approach was allowing to perform this task in a bigger workspace than the one with the conventional approach, and with bigger feasibility margins. So that hopefully that gives you an idea of how all of these methods build on top of each other to enable these new demonstrations. And so again, I'm showing a bit what's been out there in the meantime. Now, since then, we also demonstrated how we can balance two of these pendulums together. This is very different systems, but at this point, it doesn't really matter. And up to way more impressive tasks now, where we can even achieve this levitation of magnetic objects with magnetic navigation systems. And so, obviously, this is, it's hard to see how that can be clinically relevant at that point, right? But again, I'm getting back to what I said with the two-way journey in the first place. If you show that to clinicians, I'm sure they're going to be inspired by that, right? We didn't take it from the clinical needs. We said, okay, we're going to push as far as possible what we can do with the robotic systems, innovate, and inspire new applications based on this. And so, that brings me pretty much to the end of my presentation. I'm very much looking forward to look at all of these areas I'm interested in. Some of it I didn't necessarily mention today, but that's going to be my work for the next few years now as a new assistant professor. I'm also very much looking forward to collaborate with the clinicians around the Zurich area. There are plenty of them, and very exciting collaborations that are possible in this area. And I thank you for your attention. It was a pleasure for me to present to you today, and happy to answer questions.
So I have one question.
Yep.
So I guess you at the very beginning of your presentation, thank you for your great talk. At the beginning, you explained some example using the surgeon use your system using the X-ray vision, right?
Mhm.
But it does not capture the three-dimensional view. So how do you compensate this?
This is impressive, right? Well, they do that because they're very experienced to do it.
Oh, really?
Yeah, they don't have the 3D view. And I mean, it's a question, right? Like, do they need it? I mean, when you see, so the thing is, it's impressive how much of a, I mean, they have a lot of anatomical knowledge, right? When you, as a layperson, look at the image and even try to understand which vessel is in front of the other one, you would not be able to do it. But because they've seen so many cases and they can even handle, they can tell what is like a typical anatomy, what is an anomaly, whatever. They're going to be able to have a pretty deep understanding of the 3D anatomy based on that. Obviously, there is a learning curve, right? I mean, they're trained for years to do that. And the value of 3D views, I mean, they do have, I mean, again, I'm skipping the technical details, but they can have CT data, which are 3D, but these are preoperative. But usually intraoperatively, they have just a 2D view.
So, and I have one more question. So at the position estimation, I guess you use the frequency using the three-dimensional to get the three-dimensional pose, right?
Yep.
But which means that you generate the sinusoidal magnetic field, which means that it generates some current inside of some metals. So
Yes.
Is there any issue of the heating or?
With respect to, you said to heating or?
Yeah, heating.
No, heating, well, you would have to go way faster in frequencies that we are right now. The problem though, I'm mentioning a problem you didn't mention, but I have to be fair with the method. You have the same problem than any other electromagnetic tracking systems, which is that you're going to if you have a metallic object in the workspace, it's going to distort your field and it's going to affect the precision of your device. But that's not, I mean, that's not inherently a problem of our method. That's the problem of like electromagnetic tracking in the first place. But yes, it's going to distort the field. Now we can compensate for it. I mean, you can calibrate. Yeah.
Do you have any questions?
One question regarding the inverted pendulum that you showed. That was like a closed loop control system.
Yes.
Right? So I was wondering, like, like you're measuring also the magnetic fields to measure also the position of the pendulum as well to stabilize it, right? So if you add more like double pendulum, for example, would it still like work or it would be more challenging?
Actually, you don't. Well, and so the brain behind is right behind you, so you can ask him the question. I mean, you don't need the field. Actually, as a matter of fact, I think you don't need a very good model of the system, of the electromagnetic navigation system. You need very good and very fast tracking. That's the bottom line. Again, Yasan, you can say if this is wrong, but that's my understanding.
Yeah, both, I think.
Yeah. But what I mean is that we had pretty bad calibration typically for the Octomag. We were surprised on how bad the calibration could be without affecting the performance of the control. Yeah. The paper is an archive if you want. So it's not published yet, but it's out there. There was a question there.
Yeah, I was wondering what happens if the system fails. Like, can you just pull out the probe or
yeah,
you get stuck and then not be able to do anything about it?
Yeah, so the good news is that that's usually the way we argue against people who are using, because there are two competing technologies for the magnetics, one with permanent magnets that you move in space and one with electromagnets. And our argument with electromagnets is that you can always switch them off, right? So you can just put the currents to zero. There is no more like mechanical. I mean, you don't steer your device anymore. It just become like a floppy string, and then you pull it out.
So your workspace is limited to configurations where you can just pull without destroying the blood vessels, or?
Yeah, I mean, I don't think we noticed. I mean, actually, again, this is a question for this guy who worked on some of these devices. We didn't notice any damage on the vessels. I mean, that was one of the efforts actually to prove that we didn't damage the epithelial layers of the vessels when we were repeatedly navigating into these vessels. And we were surprised. I mean, now retrospectively, I don't think it was surprising, but we showed that we're putting less damage with the magnetic device than with conventional guide wires. And the reason for that is because the real guide wires, they are pre-curved, they are manually twisted and inserted and retracted from the outside. And so they need a little bit of stiffness for the mechanical stability, which we don't need in our case because we directly control the tip orientation with magnetic field. So you can think about it as you make the device rigid with the magnetic field. So if you turn the magnetic field off, the thing becomes very soft and you can pull it out. I guess that's the way to look at it.
We have one question online. So Harshid on Zoom asked, how do you account for anatomical variability when designing the system and its localization strategy?
Yeah, I don't think it's specific to localization. I would say, to be honest, I think it's still a very interesting question because I don't think there's a unique answer to that. That's probably a little bit case specific. What I can say is that what we are looking into are leveraging preoperative data. So you often have time, as I mentioned, have access to CT scan, preoperative CT scan or MRI, where you can, it's actually impressive how well they can segment vessels very quickly, very robustly with like just state-of-the-art tools, like even in clinics. And so you will have your segmenting anatomy. Of course, there is the question of reconstructing this anatomy in a model that we can actually use, right? You need some kind of meshing. I think it's still ongoing works, I would say, in that sense. And I'm not really an expert in that matter, but I would say I think it's realistic to think that you could leverage this preoperative segmentation and basically use that to plan your navigation based on that. Yeah.
Oops. If not, there's another question online. So Josh asks, is the magnetic field only guiding or steering the system, or is it also pulling the end actuator? Does this become a problem as more of the body enters the system with regard to buckling?
Yeah, so we did not use, I could have mentioned that, that's my mistake. We have a mechanical advancer that is pulling and pushing the system from the outside. I'm going to skip the tech. I mean, I can summarize the technical explanation for that, but basically it's about if you want to push and pull on your device, you would have to use magnetic gradients. You would have like to make your magnetic field vary across space. And long story short, this is you're not reaching the order of magnitude of gradients that you need to actually push and pull. It's just way easier to, especially because our device is tethered, so it's anywhere connected to the outside. It's just way more pragmatic and straightforward to do it that way.
I guess there's no more questions. Okay, thank you
Good.
for great talk.
Thank you.